Dr. Swanson.
Everyone. My name is Dr. John Swanson, and I am the president of the Delaware Academy of Medicine. It is my pleasure, as Mr. Gibbs did, to welcome all of you to the 2022 Hoops Medical Dental Lecture. I'm also the father of Andrew Swanson, a 33-year-old man with severe autism, who lives with his mother and me. And my purpose to commit my term to addressing improving the social determinants of health for adults with intellectual and developmental disabilities. As a parent, I know that it is always a challenge to complete usual and/or emergent dental visits for my son. When given an opportunity to select a speaker for this annual event, I saw it as another opportunity to advance my message on behalf of this population. We, of course, have resident experts on the Academy board, and with one voice, they all recommended our speaker, Dr. Andrew Swiatowicz, DDS. I have asked his colleague and my fellow Academy board member, Dr. Daniel Mira, to introduce Dr. Andy as he prefers to be known. But first, Robert Hoops Jr. will make a few comments on behalf of the family. Mr. Hoops.
Thanks so much, Doctor. I appreciate it and so value the connectivity between your family, your personal experience, and tonight's topic. I am hugely relieved to hear that the doctor prefers to go by Dr. Andy, as I was grappling with the full pronunciation of his last name. And Dr. O'Meara and to Tim Gibbs, thank you both for all the thought and energy you've put into not just this event, but in bringing us to this moment. I'm joined tonight by my sister Stephanie, who's also on and is far more articulate and compelling than I am, but was traveling today, so I got to get the chance to welcome you all here. And I would just want to emphasize one thing. You know, as you saw the picture of my grandfather and my father, our grandfather and our father, they're both smiling. They're both very happy, and they were happy all of their lives, and in big part was because of the business they chose, the vocation, the profession, the mission, really, of medicine that they chose, and also the state of Delaware, and the chance to do it in a community as close and as thoughtful as the Delaware medical community, and the chance to have this group together tonight to talk about what I just think is an incredibly important topic, not just in dentistry, but in any medical service or in any basic need for underserved members of our community. So I'm excited for the conversation tonight and thankful for everybody here. And with that, we'll hand it over to you, Dr. Mira.
Robert, thanks to you and Stephanie. Always good to see you on our annual pilgrimage of sorts. It's been a fun ride, and we've had some really great sessions, and really thanks to the Hoops family, because the medical dental lectureship named and cultivated by the Hoops is really important, probably more than ever. And I've probably hinted at these words in prior introductions, but you know, the merger of medicine and dentistry communicating to take care of the patient from head to toe is critical to the path forward for healthcare, and oral health is critical to systemic health or overall health. And there's more evidence to show that now more than ever, and that if we're not optimizing oral health, we're not optimizing health in general. And so this lectureship really is critical to keep the conversation going and making sure that we're really keeping the big picture in mind for patients and making oral health a priority too. So thanks again to you, Robert and Stephanie. Really appreciate it. And this topic tonight couldn't be a better one that ties that together, because you know, individuals with intellectual and developmental disabilities don't just have oral health or dental challenges. They have overall challenges with access to care, whether it's for blood work or other primary care services. They certainly have challenges. And so hopefully we think Dr. Swatowicz's, Andy's discussion tonight will give us all some tools and better understanding of how we can all do our part to take care of the patients like this. So really appreciate that. And without further ado, we'll transition with Andy talking tonight. It's really an exciting topic that again transcends, I think, dentistry and really looks at taking care of the whole patient. And particularly his topic, or some of the questions that I think are so pertinent. How do my patients experience me? ? Shifting the clinical conversation from special needs, in quotes, to compassionate accommodations. Period. Reframing the treatment of patients with intellectual and developmental disabilities to overcome obstacles that providers encounter, all providers encounter, and thus optimizing the care for the patient. We want providers to feel comfortable caring for these patients. If they feel comfortable and understand, they're more likely to provide the services. And you'll see with Andrew's work, Dr. Swiatowicz is really educating the next generation of providers, which will hopefully expand access to care and comfort in caring for these patients. So in regards to Andy, Dr. Andy, as he's being called, Andrew is actually a graduate of our residency program, is an alumnus of the program. He's a general dentist now in the Pike Creek area of Wilmington. And he's now been in practice, hard to believe, and aging myself, for over a decade, because I was here at the time. And he's a graduate of the University of Maryland from 2010. He, as I mentioned, completed his GPR, or general practice dentistry residency, at Christiana. After his GPR, he did go into private practice, where he continues to be, and has kind of two unique office offerings. He is a leader in Delaware dental sleep medicine. And he also, in terms of treating sleep-related disorders from an oral dental perspective. And he also has Swiatowicz Dental Associates, where he's treating patients of all ages, but has a particular focus on those. And he's actually has additional training on caring for those patients with intellectual and developmental disabilities. And as you would imagine, patients are coming from all over the Mid-Atlantic region to seek out care, because it is very hard to find good access. And so hopefully we're remedying that. And how are we doing that? Well, Dr. Swiatowicz is section chief in our first section chief for special care dentistry and dental sleep medicine in our department of oral maxillofacial surgery and hospital dentistry, where he's not only educating the next round of residents, but he's also creating a structured program to help us provide access to care for those patients too, with him leading the way. So really excited to hear what he has to say. I think we all have something to learn tonight, and hopefully we can all do our part to care for this population of patients. Dr. Swiatowicz, thank you and welcome.
Thank you very much. Let me just get my screen up here for everyone.
You've got it.
All right. So far, so good then. Wonderful. All right. Thank you, Dr. Mira. Before I begin, I want to actually point out that one of my colleagues, Connie Ciccarelli, brought to my attention when she was registering for this course that today is March 21st, or World Down Syndrome Day. So I'm very grateful to have the opportunity to be giving this talk on this important day. I want to start our lecture tonight by putting up two photos on the screen. First, we have a scuba diver. What do you see in this photo? Maybe you see someone who's adventurous, athletic, even heroic, someone who excels, somebody who represents the pinnacle of human achievement. Now I want to show you a second image. What do you see here? The first thing you may see is a ventilator. This woman's name is Alice Wong, and she's the founder of the Disability Visibility Project, a collection of oral histories from people with disabilities. She's recently been writing about her experiences as a disabled woman during COVID. Now I'm going to invite you to take a look at both of these images side by side. For all of the differences, we are essentially looking at the same thing, a human being attached to something to help them breathe. But I'm not sure that everyone sees it that way. With the scuba diver, we might see a person connected to a breathing machine. With Alice, we might see a machine connected to a person. The first image, we interpret as an excess. The second, as a lack. Why might that be? That's one of the questions I want to explore with you all tonight. The title of my talk is How Do My Patients Experience Me? Shifting clinical conversations from special needs to compassionate accommodations. I want to invite us to rethink these terms. If I had started this talk with putting those two images side by side and asking you which one, quote, showed a special need, I imagine that many of you might point to Alice. And that makes sense because we live in a culture that has taught us to think about disability in a certain way. But the thing to realize is that neither of these people have a special need. They have the same need, which is to breathe. And it just so happens that in their respective environments, both of them need a particular accommodation to help them achieve their need. I want to cover a few things with this course tonight. First, I want to identify and explain several important keywords in the field of disability studies. Then, we'll give examples of how we can bring some of our new understandings of these keywords into our practice. And finally, I want us all to be able to rethink how we as clinicians can interact with our intellectually and developmentally disabled patients. For the past 15 years, I've focused my career on working with at-risk and often neglected populations. And my experiences with these patients have changed the way I work clinically with not just the intellectual and developmentally disabled, IDD population, but all of my patients. I was fortunate to begin this journey early in my career, and I can really truthfully promise you, I was not prepared. In dental school, we would rotate through the special patients clinic, which was specifically for medically compromised and IDD patients. Here, I had the privilege of working with this population on a variety of procedures, and it really removed the stigma that some healthcare providers perceive when treating patients with IDDs. Fast forward to my residency, where I was given a new opportunity. Here, I learned how to provide care under sedation for patients with IDD. Although the clinical procedures were the same as what I learned in school, the means of delivery, planning of the case, and coordination with caregivers were new skills I developed. And these educational experiences were formative in creating my vision for private practice. Today, we make comprehensive care for patients with IDDs a priority. And we can provide that care in both a traditional office setting and the operating room when needed. Throughout my career, many of my preconceptions about, quote, special needs population were challenged. And tonight, I invite all of you to reflect about your experiences and challenge yourself on what you thought you knew and how you can think about working with these populations differently in your own private practice. This is an image of Helen Keller and her teacher, Anne Sullivan. As many people know, Sullivan at first struggled to teach Keller to use language. But on April 5th, 1877, both people experienced breakthrough together.
I just wanted to say, if you wanted to pop in and just see what he's doing, you're very welcome.
Okay, there. All right. Here's how Helen recounts the story in her autobiography. We walked down the path to the well house, attracted by the fragrance of the honeysuckle with which it was covered. Someone was drawing water, and my teacher placed my hand under the spout. As the cool stream gushed over one hand, she spelled into the other word, water, first slowly, then rapidly. I stood still, my whole attention fixed upon the motions of her fingers. Suddenly, I felt a misty consciousness as of something forgotten, a thrill of returning thought. And somehow the mystery of language was revealed to me. I knew that W-A-T-E-R meant the wonderful, cool something that was flowing over my hand. That living word awakened my soul, gave it light, hope, joy, set it free. There were barriers still, it is true, but barriers that could in time be swept away. I left the well house eager to learn. Everything had a name, and each name gave birth to a new thought. And as we returned to the house, every object which I touched seemed to quiver with life. That was because I saw everything with the strange new sight that had come to me. Language throws open new possibilities for those who know how to use it. Words, as Helen Keller learned that day, make the world blossom for us. We should be mindful of our language, not because it is the popular thing to do at the cultural moment in time, but because the world we encounter is at every moment shaped and formed by the way we speak to it and about it, and even by the way we hear it speaking to us. A lot of my growth as a clinician working with disabled people came from rethinking certain words and phrases that have been deeply ingrained into me. Words like special needs, impairment, ability, handicap. Again, it's not that these words are politically incorrect. On a factual level, the popular understanding of these words do not correspond to the lived realities of our patients with IDDs. My husband always tells me that words matter, and usually that phrase signals to me that I've lost an argument. However, and as always, he's right. When we provide a clear understanding of certain terms, it can change the way we act. With that in mind, I want to review a few key words that can start to shift how we as healthcare providers interact with our patients, or more importantly, change how our patients experience us. The words I want to talk about today are key words in the field of disability studies. And this field may be a new concept for many of us. It was for me when I first started to focus on my practice and working with patients with IDDs. Disability studies explores the social, cultural, and political dimensions of the concept of disability and what it means to be disabled. It emerged alongside the civil rights movement of the 60s and 70s with many of the same goals, affirming basic human rights of dignity and respect. One very important thing about this field is that its research is pioneered by people with disabilities. So disability studies thinkers and advocates and activists are including disabled people as conversation partners, and this is crucial. Now, many of the disabled people who champion disability studies are physically disabled. However, many of my patients have intellectual disabilities. So what I'm trying to do is to listen to the voices of disability scholars and provide creative ways to apply that to my patient population. So first, I want to start talking about the term disability. Disability. What do you hear with that word? Someone is lacking ability to do something. It's commonly associated with words like infirmity, deformity, invalid, deviance, disorder. In this conception of disability, disability has a very particular location, and that is within the disabled person's body. When we look at disability studies, there are three models of how we view it, disability. The first is the medical model. Here, disability is seen as an impairment, something to be corrected or cured. In this model, disability is located solely within the body. On the other end of the spectrum, we have the social model of disability. Through the lens of the social model, someone is disabled because of the attitudes of those around them. Here, disability is located completely outside of the body, solely in the institutional practices and environmental structures. The third model is situated somewhere in the middle, utilizing concepts from both to theorize disability, and that's the biocultural model. On this model, disability emerges when particular bodies engage with other bodies in specific environments. Or said another way, we see disability emerging as a relationship between these two things. With this model, we don't say disability is located exclusively in the body or in society, but instead that disability happens in the interrelationship of both of these things. The model doesn't emphasize pathology as the disabling factor. Instead, it focuses on how bodies are disabled by other factors, including physical barriers, social stigma, and the lack of legal recognition, adaptive technologies, and economic resources. As healthcare providers, disability is a word that most of us feel confident in understanding. It feels very medical to us. We look for a physical cause and a cure or a treatment for what's in front of us. However, disability is produced as much by environmental and social factors as it is by its bodily conditions. Importantly, we cannot view disability as deficiency of the mind and body. Instead, it is a relationship between the body and society. As the authors in Keywords in Disability Studies put it, disability, quote, begins and ends with the subjective impressions of the individual who experiences the world through their body. That's a key concept I want you to keep in mind. Disability is in part because of the individual experience. I asked where disability is located, and that's kind of a trick question, because the answer is that disability is not located in a particular place. Disability happens. My follow-up question is, when does disability happen? And the answer to that is that disability can happen at any given time. We tend to think of people in two categories, the disabled or the able-bodied. Disability studies offers us a different, more provocative way to see ourselves as disabled or not yet disabled. Many people spend a portion of their lives, often towards the end of their lives, cognitively and physically impaired. Many people die with disabilities that only emerged in their lives after the onset of injury. Illnesses or injuries that may have so far escaped us only by luck. And for that reason, disability scholars encourage us to see the world as disabled and not yet disabled. In a sense, they're challenging us to say, and when this does finally happen to you or a loved one, don't you want to be in a world where people are kind to the disabled? Another key word for us is ability. Ability is normative in the Western world. It's seen as the de facto uncorrupted state of human beings when we are who we are supposed to be. Or ability means your disability has not yet emerged, or that it is emerging slowly enough that it can be discreetly accommodated. Disability and ability are co-constituted. Each term needs the other to be what it is. Importantly, ability is not the antithesis of disability. Let's imagine this story. I don't live far from the Delaware School for the Deaf. And I should say before I bring this up that many deaf people do not include deafness as a disability, but as a culture. However, I'm still going to give this example as it illustrates a point. A student at the Delaware School for the Deaf spends their days in an environment where they are fully abled. They can communicate with everyone around them. They are not limited by their deafness or American Sign Language. Now, let's say during gym, the student gets hurt and has to be rushed to an emergency room. In this new environment, no one communicates like the student does. Traditionally, we've been taught to locate disability in the deaf student. What I'm suggesting is the inability exists within the hospital staff who's not able to communicate with the student as she is able. Able, that's important. The student has the ability to communicate. Who in this situation then is not able? It's not, quote, the disabled person. Going back to Miss Wong and the scuba diver is a perfect example of what our next term, medicalization, is. The scuba diver skier is not medicalized because we don't see him as disabled, even though both pieces of equipment do the exact same thing. They help someone breathe. And the key question here is, who are the people doing the medicalizing? We do. Healthcare providers, politicians, society. We decide what phenomena to medicalize and to not. As healthcare providers, we may not initially see this as a bad thing. We're advocating for our patients the best way we know how, through our medical knowledge, care, treatment. We know that without the right medical diagnosis, those with disabilities will be denied life-saving and life-enhancing benefits, therapies, equipment, funding. Medicine, as Scianti Dasgupta puts it, has become, quote, a social gatekeeper, forcing many individuals with disabilities to acquiesce to diagnostic categorization. Again, I wouldn't say that is necessarily a bad thing, at least for the time being, given our current healthcare system. But even though I have to be able to navigate the difficult system of insurance and coding and billing in ways that insurance companies require of me, I can and should resist the temptation to bring the rhetoric of medicalization into my patient interactions. My practice as a clinician working with IDD patients is to essentially follow their lead. And while I don't always like that I have to do it this way, that's what the insurance companies require of me. They set the grounds for these conversations, so I use their words, even as I hope that one day their words might reflect the important advances that disability scholars have made. It's also important to point out that while disability itself should not be treated as a sickness, disabled people do get sick. There is such a thing as an unhealthy disabled person, and those patients need treatment. However, we should be aware that what we are treating is the disabled person's illness, not their disability. Accommodate means to make something suitable for someone, and that's what our next term is. There are two ways of understanding accommodation. The first is to tweak the existing baseline to make room for a certain kind of disabled person. The other way to understand it is that, as Elizabeth F. Emmons says, accommodations take disability as the impetus to recalibrate the baseline for everyone. In a biocultural model of disability, if the accommodations are right, disability does not emerge as an impairment. Sometimes patients bring their own accommodations. Sometimes we make the accommodation. But when you accommodate your disabled patient, what we're really doing is making sure they feel fully welcome and cared for in a way they need to be. As clinicians, that's what we do with every single patient we encounter, including our not yet disabled patients. But chances are we do not think of ourselves as accommodating them because we don't think of them as disabled. As a dentist, I may look at my schedule one day and see a patient who I know will take up more of my time during the appointment. She may want frequent breaks, like to hold the suction herself, and check her bite of the filling we just completed, sitting upright and lying down. The accommodations I make for this patient during her appointment don't get a medical diagnosis in her chart. They just happen. However, if those same accommodations are needed for a patient with intellectual and developmental disabilities, we can fall into the trap of seeing that accommodation as a result of their diagnosis, and therefore thinking about it as an extra step that we don't really have to do with our non-IDD patients. What I'm really hoping you're starting to see is that there really are no such things as special needs. All of our patients have the same need, and that's to be cared for the way that they require. It is, however, important to note that there is a legal definition of accommodation, and that definition has made the world in general a little less difficult for many disabled people to navigate. Under the American with Disabilities Act, it is discriminatory to not make reasonable accommodations. And that's interesting because usually discrimination involves you doing something. But under current law, when it comes to accommodations, discrimination is constituted by not doing something. A huge barrier to accommodation is that we often see it as costly and burdensome. Why should we have to spend a lot of money that's only going to benefit a few of our patients? But as Emmons points out, most accommodations are not costly, and many impose no direct cost at all. Furthermore, she points out disability accommodations often benefit us all. Ramps are not only helpful to people in wheelchairs, but they assist any of us using strollers, suitcases, bicycles. Automatic doors are good for anyone leaving the grocery store with their handfuls. But moreover, when we as clinicians are mindful about accommodating practices, all of our patients benefit because they're being treated by healthcare providers who are committed to patient-centered care. One question that arises in discussions with accommodations is, accommodations for whom? As Emmons points out, sometimes the same accommodations that are beneficial to some IDD patients pose new challenges to other IDD people. An example of this is curb cuts. These are helpful to wheelchair users, but disorienting to those who are blind. What this means is that when creating accommodations, we should be mindful of intersectionality, which is the last word I want to discuss. The Oxford English Dictionary defines intersectionality as the interconnected nature of social categorizations, such as race, class, and gender, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. The term comes from Kimberly Crenshaw's 1989 paper titled Demarginalizing the Intersection of Race and Sex. Crenshaw was essentially trying to show that when you're Black, you have one set of challenges. When you're a woman, you have another set. And when you're a Black woman, entirely new challenges may emerge. Intersectionality is a theory that helps us understand what is going on in the center of this, at the overlap of all the marginalized identities that our patients may possess. Here's an example to help illustrate this point a bit. I have a young male patient with an intellectual disability. His parents were able to focus on providing extra education and accommodations at home to maximize his potential for success. Other patients of mine have more overlapping challenges. One of my patients is a young Black woman with an intellectual disability who's also hard of hearing. The theory of intersectionality helps me recognize that the effects of her different identities are compounded. And so my challenge as a healthcare provider is to make sure that my care takes into account all of those things. With my first patient, nearly any treatment option suggested by any of his providers is a viable option and promptly pursued by his parents. With my second patient, we have to be more creative with our treatment plans. So now that we have a new understanding of some key ideas around disability, I want to start looking at how we interact clinically with our IDD patients. I titled this talk, How Do My Patients Experience Me? What do you notice about this sentence? How do my patients experience me? Every day as a healthcare provider, I see patients, I diagnose, I treat dental problems, I educate patients on oral health. I stay in the same office. Patients come to me. They step into my world. And every single day, if I'm not careful, I see myself as the primary subject in all of my patient interactions. I remember early on in my career, I walked into the room for a new patient consult with an IDD patient. They were seated in the dental chair and had a caregiver with them from the group home they lived at. I introduced myself to the patient and reached out to shake his hand. Before I could say anything else, though, the caregiver in the corner said to me, "He can't talk or understand you." I remember being taken aback by that comment. Essentially, what the caregiver was saying to me was that my patient could not experience me. But of course he can. However, his experience of me is shaped by his disability. The caregiver was not trying to be disrespectful of the patient, but without realizing it in that moment, he deprived him of his subjecthood. Years later, I had a similar encounter. A father and son came in for a cleaning appointment. The father seemed nervous for his son, who had an intellectual disability. He was answering questions for him and talking over him throughout the appointment. After cleaning his teeth, I said to the patient, "All right, I've got a big choice for you today. What flavored toothpaste would you like me to brush your teeth with? Mint, cherry, cinnamon, pina colada, chocolate, or bubblegum?" "Bubblegum," he said emphatically. The father immediately responded, "If you give him a list of things, he just picks the last one." In both of these instances, even though I spoke to my patient, their caregiver spoke to me about them. And to be clear, many of my patients with intellectual and developmental disabilities do not speak, but I still address them as the patient because they are the patient. And even when they can't or don't speak, I still try in all of my interactions to slow down and think about how they are experiencing me. I'm always very proud that my entire team at the office strives to do this as well. Recently, however, something happened which gave us an opportunity to recommit to this practice. We had a new patient in for her routine cleaning and exam. The patient had been successfully able to receive dental care in the office prior to becoming a patient of ours. Medically, she had a diagnosis of Down syndrome and moderate intellectual disability. She liked to chatter and look around at the new sights in the room. Once the cleaning was complete, I received a pop-up from our intra-office messaging system that said, "Patient anxious, please come fast." Now, maybe the patient was anxious. As you've all experienced at some time, IDD patients can be anxious in a medical setting. However, when I came into the room, the patient didn't appear anxious. So I wondered why a hygienist who's wonderful when it comes to caring for IDD patients wrote me that note. I also wondered if the patient was able to send me a message ahead of time, what would she have told me about her hygienist? How do my patients experience me? When we are experiencing our patients as anxious, uncooperative, or disruptive, are they experiencing us as forceful, impatient, and demanding? I do much of my continuing education at a place called the Pankey Institute. It's based on the clinical philosophy of Dr. L.D. Pankey. And he's famous for saying, "I never saw a tooth walk into my office." In other words, as a dentist, I do not treat teeth. I treat people who just so happen to have teeth. My associate, John Fasciolo, taught me a saying that he learned in dental school, which gets at the same thing. There's a person attached to that tooth, a family attached to the person, and a community attached to that family. I think the patient encounters I described illustrate the unique opportunities that we as healthcare providers have. Our care for IDD patients is not limited to specific treatments we perform. With the first patient, maybe I was the only person that provided him a physical touch through a handshake that day. And maybe the only person that day to offer the son a choice that he got to decide on his own. And maybe I was the first person to model for his father new possibilities for interacting with his child. Our work with these patients extends beyond treating illness. We have the unique opportunity to collaborate with our IDD patients in constructing a world where able bodies are the not taken for granted norm and disabled persons occupy a special place of pride. This potential for collaboration is perfectly illustrated by the poem "Working Together" by disability rights activist Laura Hershey. Her job, brisk bristle circle on the teeth. My job, sneer, open wide. Her job, apply soap, loofah, hot spray. My job, how hot, say stop. The poem shows the disabled person and the abled supporter working together on the same task. According to Katerina Sioku, in this poem, quote, "The disabled person is not perceived as a passive dependent subject, but an agent. This collaboration," she says, "marks a new space of physical expression and physical relationship, which is characterized by corporeal interaction, mutual trust, and profound intimacy." What I love about this poem, besides the fact that it starts with brushing your teeth, is that it perfectly illustrates the ideal interaction between IDD patient and healthcare provider. There is mutuality here. Both parties are collaborating on the same end, which is compassionate healthcare. Whose job is more important? Both are necessary if the task is to be accomplished. There's an intersubjectivity here, not a subject encountering an object, but two subjects experiencing each other and experiencing each other. I began this talk by offering you two images to reflect about. And usually when I show these images to people, they reflect on the differences. What I'm wanting us to do is think about the similarities. Both are of people with particular bodies which interact with their contexts in a specific way. And as a result of that interaction, certain accommodations are necessary for the person to thrive. Both breathing apparatuses too become sites of meaning making, where our experiences as onlookers come to bear as we begin to think about and relate to the bodies who use these accommodations. How does a scuba diver experience his breathing apparatus? Is it different than the way people with respiratory insufficiency use their breathing accommodation? I'll use the words of disability scholar Carol Gill to answer that question herself. She says, media stories of non-sentient or suffering people helplessly tethered to tubes and machines are the horror tales of our age. Although no one pities the scuba diver or astronaut who uses a breathing device, ventilators, used quite comfortably by people with respiratory insufficiency, are viewed as the definitive mark of subhuman existence. If only Nike or Apple would launch an advertising campaign to rehabilitate that image. Too often, when we think about disability, we think about it from our experience of it. But when we listen to disability scholars and other disabled persons, our perspectives are challenged and opened up. Taking my lead from these scholars, I've offered you new ways to think about important key words, including disability, ability, medicalization, accommodation, intersectionality. I've also encouraged you to reflect on the clinical interactions you've had with IDD patients and to suggest new possibilities for future encounters where you may make a concerted effort to center and privilege your IDD patient's subjecthood. Subjecthood. It's something I emphasized in this talk. How do our patients experience us? But I want to leave you with other important and often neglected questions to reflect on. How does our world experience disability? What do our disabled patients contribute to our shared world? How is our world improved by disability? And closer to home, how are our practices improved by our work with disabled populations? What do my disabled patients add to Swiatowicz Dental Associates? When we stop thinking of disability as something to be overcome and cured, we're free to reflect on the contributions that disability and disabled people make. In terms of my individual practice, working with IDD patients has given me the opportunity to grow enormously as a healthcare provider. Every day, I'm reminded to stay curious, to remain flexible, to be adaptable, to turn off autopilot, to slow down, to think about what my patient is telling me without their words. These reminders are prompted by my IDD patients and carried over into all of my patient interactions. In medical education, we're often taught to think about patient success in terms of autonomy and quantifiable outcomes. But our work with IDD populations reminds us that one of the most important standards we should be holding ourselves to is a standard of compassion. Thank you for taking the time tonight to open your minds to new ways of working with the intellectual and developmentally disabled population. I encourage you to take these ideas into your practice and see how you can adjust the way that you provide clinical care to all of your patients. Thank you.
Doctor, thank you very much. What we can do now is use the chat. If you have any questions, or alternately, you can raise your hand and I will then call on you to unmute. Give people a couple of minutes to see if they have any questions and follow up.
And Tim, I'll jump in there. And so,
Please do.
Dr. Swiatowicz, awesome. Really appreciate that. You know, as I alluded to, it was a discussion that wasn't just centric on oral health and dentistry, but was global around opportunities for all of us. And so but to your personal experience, kind of in a more granular state, what are some of the things you did initially? You alluded to some of it, but in more detail, to get your team members, your staff to kind of think and feel comfortable in the same way, or to redesign how patient flow occurs, or even how the clinic or your practice may flow, so that the experience for these patients, how they experience care and the barriers to that care are reduced. So, how, you didn't get to where you are necessarily exactly overnight. It was a process, and a process you've been clearly studying and learning. But I guess what I'm asking is, what are some take homes for the audience to say, tomorrow I could start to do these things. Now that I understand the bigger concepts, I could start to do these specific things that would really make a difference for the patient and how they experience, the team.
And thank you, Dan, for those the comments and the question. I would say the first thing is just to not be afraid and to stay curious. I approach every interaction with our IDD patients wanting to learn something from them and wanting to be surprised at what we can do together. And keeping that open mind really is the start of what you need in working with this population. You mentioned my team and how I got them involved. If I could go back in time, I probably wouldn't have just thrown everybody into the deep end and said, we're doing this, and provided a little more training with it. But I think in part that's how they responded so well too, is they knew it was important for the patient population. They knew that I saw it as important. So they took on that curiosity and took away that fear and did what they could with the patients. A lot of times, and one of the unique things about my practice is I have the added benefit that if I can't safely and comprehensively complete what I need to do with my patient in an office setting, I do have the ability to bring the patient to the operating room to provide that baseline care, and then recalibrate with the patient on how we can compassionately provide that care in an office setting and not have to go under anesthesia every time. So I always have that in my back pocket, which is certainly a nice thing to have, that I know everybody can have, although I encourage you to pursue it if you're a general dentist looking to get into it. But it really is just trusting your own knowledge and your own care to work with the patients, and really take away that fear and stigma that may come with it, and just go for it. Start easy too. I didn't try to, the first time I was working with this patient population and I saw a tooth needed to be pulled, I didn't come right at them and say, this is what we're doing today. You build the trust, you build the relationship, and let them kind of guide that experience that they can have with you. And you'll always be surprised. I can't tell you how many times I've had a parent come in with a patient who's 24 years old with a moderate degree of autism, and they'll say, he's never been able to have anything done in the office. He's never been able to have his teeth cleaned. And what we're able to do in those appointments, I love when the parents say, how did you get to do that? And most of the time is, I treated my patient like a patient. I collaborated in my care with him. I utilized maybe the parent or the caregiver with me as that support and the trust to get the work done.
As a follow-up, I'm curious, despite all the good work you've done and in your team's understanding of the process and the commitment to taking care of these patients, but we need more global solutions to improve access on a more grand scale. So kind of a two-part question here. What do you still find is some of the biggest barriers you as an experienced team face in caring for patients like this? And then how do you get build a critical mass of providers that can comfortably care for patients and provide increased access, so that in 5 years, we're not looking at the same situation that we are today, but we've made progress in the right direction. So two parts there.
Yeah, and I'll try to touch on both of those things for you, Dan. A lot of what I think you can do with this community is work with partners in the community. We as healthcare providers, we can advocate in a lot of ways, but a lot of times our skill set is best used for that patient care and the patient interaction. So we work with the community groups like Mosaic is a group in the community on a national level, but we have a great organization right here in Delaware that works to enable these patient populations to be successful, not just in dental care with me and healthcare in general, but in life and work and living on their own. And they really do help to almost quarterback some of those challenges that a patient with intellectual disability may have, and put them in contact with the right people. And I know, as an example, last week, collaborative care is so key between healthcare providers, and reaching out and working with them to provide those services for the patients. And you and I were in the operating room together with patients last week. We work with Dr. Wright and Dr. Petrides and her clinic, and the transitions clinic at Christiana, Dr. Smalls with women's health. We work with ophthalmology, podiatry. Also, we can work with the patient's best interest in mind and help them to receive that care in a compassionate way. And it's getting out and talking about those experiences with other healthcare providers also, in getting them excited to be part of that at any level. Maybe it is just seeing patients in their office to help get them streamlined to the right place, or do what they can with oral home care before getting them to a dentist who may be able to sedate or do work under sedation. So when there are healthcare providers who are comfortable and passionate about working with this population, it just involves them getting out there and sharing that passion and getting people involved with it, which I think is why it's so great that with the residency program, we can share that with them and get them curious and wanting to learn a little more and dip their toes in the water to move that further. And hopefully, like you said, in 5 years, have more doctors more comfortable treating these patients.
Yeah, outstanding. Thank you, Andy.
Yeah,
All right. I've got some questions from the chat. What kind of training would be helpful for medical dental staff, I gather, to assist both you and the patients that you serve in common?
That's a great question. Like I said, I kind of just dove headfirst into the deep end and said, we're doing this, let's go. There were some benefits to doing it that way, but there's also a lot of resources and education out there. I know within the dental world, there's an entire organization called the Special Care Dentistry Association that has continuing education and resources to help dentists work with these varying populations in the special patients community. And I would imagine the medical community has a sister organization to what we have. You can reach out to those healthcare providers who do it and say, hey, can I come in one day and see what you do with these patients? Because I can guarantee in almost every day, we will have a unique interaction that we can learn from with our patients there. There are groups also that locally within the state that you can gather resources from. Like I said, I mentioned Mosaic earlier is a great group that provides resources to patients, providers, loved ones, and community members. So there's a lot out there. Sometimes you have to do some digging, but I'm always open to passing on any information if people do want to contact me directly about that.
All right. Next questions, they're similar enough that I'll ask them together. From Dr. Swanson, what experience with this population impacted the interactions of you and your team with all of your patients? So that's part one. And then part two from Dr. Patricia Curtin. I imagine your approach would work with our dementia patients. Do you see those patients or know of practices that do? Thank you for this excellent and inspiring presentation and for all that you do.
Well, and I believe Dr. Swanson's question is in there, so I want to see both of these at the same time on my screen. So what experiences will have impacted us to kind of transition to all care? And I really think the most important thing when I was thinking through this lecture and talking about it with my husband is working with patients with intellectual and developmental disabilities really does take you off autopilot. Too many times in healthcare, we say, all right, diagnosis X is in front of us. To treat this, we do ABC, and we're done. That isn't always the option in working with this patient population, and it's not always the best way to treat all of our patients. So by keeping ourselves alert and creative and thinking of different ways to provide care, it really does benefit all of our patients. I mean, think of yourself as a patient. Do you want to go to a doctor who just hears your complaint and goes through the flow chart? I mean, think of how upset you get when you're on Amazon customer service and you type in things and they automatically respond to that. So that's one of the most important experiences I gained that translates over to all of patient care. And you're right, Dr. Curtin, that yes, a lot of working with the intellectual and developmentally disabled population really does translate into the care of patients who have dementia. I mentioned earlier in the talk that we really do need to shift our focus of not able-bodied and disabled, but to disabled and not yet disabled, because that really does kind of tie into those cognitive impairments that come with dementia. And if we can start focusing on that, on how we view our patients and view ourselves, that allows us to see things a little more compassionately, be a little more patient with our care, slow down and focus on the care we provide to the person in front of us. So I hope that answers some of it.
Yep. Dr. Public Health, my field, spends a lot of time thinking about policy development and supporting legislation. If you had a magic wand, what would you like to see us doing in Dover and on Helen, Washington, that would directly benefit the population that we're talking about this evening?
Infinite resources, but I know that's a very large wish list. And while that would be great, we know that money doesn't solve everything, and just providing things for these people, whether it's finances or therapies or access, doesn't result in a global change. I think an important thing to do would be to introduce policymakers to patients with intellectual and developmental disabilities. Because like I said in that first example, when we see a photo of a patient, we immediately think certain things. And that's not wrong that we think them as the first thought. But I'm sure all of us as healthcare providers have had very different interactions than we thought we were going to have with the still photo of a patient and the living patient in front of us. So when you start to see that, it can, under policymakers, maybe light a fire. Under just human beings, make a change in perception. So I think that's a really critical thing that we can do with our policymakers in government. And it was interesting in doing some research for this lecture and looking at the timeline of how our work on the legislative side with disabled populations has really shifted over the years. And it really is a recent phenomenon since the ADA was in 1990, 1991. So we're still relatively new, and we can still make changes from what we're learning on it. So introducing people, and then, like I said, infinite amount of money will be two things I would love to see being done on the public health side.
Dr. Muir, oh, I see a question from, oh, I'm going to butcher this name, Carmelina Daro.
Good job.
I hope I didn't do that too badly. Oh, hold on.
Muted.
There you go. Try again.
Okay, can you hear me now?
Yes.
Yeah.
Andy, it's so great to see you. I'm so proud of you. You
Oh, thanks.
feel the love. You're so passionate about this special population. I wanted to share also, I've been working at a practice in Pike Creek as well, called Practice Without Pressure for the past year. And it's a philosophy of care for special needs patients that is really, really effective. I have witnessed patients who start off and all they can do is pound their fists on a chair. And through the process of this philosophy, they're able to sit through an entire restoration. It seems almost miraculous. So to answer, Tim, your question about a dream, a wish list for legislation, this process of taking somebody from not being able to do anything, even sit in a chair, to being able to sit through a restoration is accomplished through a coaching process. And Practice Without Pressure, which I'm a big fan of, uses a practice specialist. So it takes away the onus from the dentist or the medical provider. The economics don't allow us to do this much, but a practice specialist, we need an army of practice specialists who will coach patients, taking baby steps, training them, rewarding them every step of the way to the point where they can sit for a filling or a pelvic exam. It is possible, but we need the manpower of these coaches that will get people to that point where they can do the task. So that's my wish list. And thank you, Andy. Thank you, everyone.
Thank you, Dr. Darrow. And that's a great point that's brought up, is having the manpower for collaborative care with this patient really is key. It's having this relationship between a caregiver and the patient and the healthcare provider and the family and the group home manager all working together with the same goal really does help those patients get to that success and that optimal health we can provide them. And that's a great thing to have. I mean, I would love to see more providers, more dental providers and healthcare providers treating this patient population and feeling confident in doing that. That's, like we talked about earlier with Dr. Muir, getting some training and understanding and experience with it will help us be able to spread the care of these patients that will be compassionate and collaborative. And we just need those people wanting to say, hey, I want to make this shift. I want to try to incorporate some of these things into my practice, and adding that manpower to the entire pool will benefit all of these patients in Delaware.
It's wonderful to see all the the great comments, great presentation, Dr. Andy. Words matter, people first language, spot on. Mosaic is always grateful for your compassionate care and service, as well as your advocacy for people with IDD in our community. It's really nice to see that there. Any other questions from the group?
So Tim, I just want to follow up with what Carmelina, Dr. Darrow was saying too, a little bit. I mean, there's always a reality in healthcare, and for better or for worse, we don't like it. We don't like to talk about it, but healthcare is a business still. And so how do you follow up to kind of dovetail off of Dr. Darrow's question? How do you, because I think about what are the reasons people have a hard time entering this field to take care of any population of patients that's more challenging or more difficult. And, sometimes one of the excuses is, financially it makes it difficult because quote unquote, I got to pay all the staff and keep the lights on. So how do you knock that, that concern away or minimize it to some degree that lowers the barrier to entry for people to get involved in care of populations that sometimes appear to be more challenging than maybe the reality is? And yes, we don't have unlimited resources, but clearly individuals like yourself are doing this. How do you make it work?
Part of it is just that commitment to want to do it, because you're right, there are challenges. There are times when we do bring a patient in and we're not able to accomplish everything we wanted to for that appointment. And that does take away from part of the patient care we can provide to other people in our practice. But the fortunate thing that I have right now is I've been doing this long enough that I can kind of identify when those challenges can come up. Luckily, I'm not as often, I won't say never, not as often surprised that, wow, we set aside this time and we couldn't do what we thought we could work with the patient on today. During COVID, actually, one of the best things that could have happened, if you can say that about a global pandemic, was the rise in telehealth. And we've been utilizing that a lot with our practice to the benefit of the patients, because a patient who it may be difficult for transport or going into a new office, we're able to at least evaluate them and get a feel for what they may be able to work with us on in the office in the comfort of their own home first. So using telehealth has helped us. And from a, like you said, a business side of things, that also allows us to free up chair time without getting into too much the nitty gritty of a dental practice. My dental assistant could be fitting a crown for a patient when I'm doing a telehealth at the same time. So we're able to use technology and use our experience to maximize what we're able to provide in terms of care for the patient. So a lot of it does take you have to get into it and see what you're capable of doing with your patient and adjusting from there. Like Dr. Darrow said, with Practice Without Pressure, they're fortunate to have doctor time being dedicated for one thing and practice specialists being dedicated to that other part of the practice to get the patient to the doctor time. So they're really able to work that together. So it's tough at first, very rewarding, not just from the business side of things, but I always say to people when I talk about working with this population, it is the most professionally and emotionally rewarding thing I do in my practice. I love doing nice aesthetic work for patients. I love treating sleep apnea and somebody telling me that they sleep well. I really love doing a simple one surface filling on a patient who's never been able to get dental work done in the office before, and a parent is just blown away by that. That is really cool. And that has its own rewards to you as a healthcare provider.
Yeah, kudos and this is my last comment, last question before I turn it back over to Tim. But there is a concept in cleft care around the cleft team. So the patient themselves goes to the cleft team and sees the nutritionist, sees maybe the behavioral health specialist, sees the pediatric dentist, sees the pediatrician, sees the surgeon. Everybody is there, circled there for the singular purpose of caring for that patient as a team at the same time, so that there can be communication, generating of treatment plans and a plan for the next, say, 3 to 6 months. It's a cleft team, and a lot of most of the major children's hospitals have these. Have you come across, read about, thought about, on even less of a grand scale, the concept of a IDD team, so that at one appointment, the family, the patient, there's a plan for all of their needs? Yeah, so-and-so is going to need blood work in a couple of days. They're going to need to have their GYN procedure. They're going to need to have their oral health address, so that everything is planned and coordinated as a team around the patient in the center of this discussion. Because what you're describing is a team of sorts, but having to go from part to piece to part, which is difficult for families, taking time off of work, getting transportation, taking them from specialized group homes or whatever it may be, really is complex. Do you foresee a day where something like that could work?
Yeah, I think especially at Christiana Care, where we are uniquely positioned to kind of start that idea and start creating that could be a great model for other hospitals and at a national level. With the transitions clinic with Dr. Wright and Dr. Petrides there, that's a great opportunity to say, hey, let's all get together with this patient at the same time and come up with that game plan, like you said. Right now, what we kind of do is, if we have a patient that the transitions clinic will identify as need of dental health, women's health, ophthalmology, and we know they need to be sedated, all of us jump on in at the same time while the patient's under anesthesia. We do well, I do just the teeth part, to be clear, but we do all of that stuff, and including blood draws that may be difficult, vaccinations, podiatry. So yeah, having that home base with all of the providers is a really great way of thinking outside of the box to help treat these populations. And I think it can spill over from just under sedation, getting it done, to having that all collaborated within the hospital system too.
Well, thanks. Kudos for all the great work you're doing, and not only in terms of taking care of the patients, but on behalf of the department and all you're doing to educate the next generation of providers that hopefully will expand and grow the work that you're doing. So appreciate everything tonight. Thanks so much.
Cool.
Fantastic, Andy. And Tim, back to you.
Tim, can I have 1 second here?
You sure can.
Yes. Okay. So I just to point out everyone, the idea of overall cost, though, to the, if you can de-escalate care from an OR to an office, huge savings. The second thing, as an end user, anything that you do to make my son less anxious, not afraid, and can go to his visit, it is so, and his friends, it's such a game changer for a family. It provides peace and good dental health. So I want to thank you from the Academy for your great lecture. Exceeded anything that I expected. Thank you so much. And the other thing is, from a grateful parent, thanks for what you do for our kids.
Thank you.
All righty, and let me just go over the CME and CE details again. But first, thank you, Dr. Andy, very much. That was outstanding. And thank you also to the Hoops family for your support of this lecture series. It's deeply appreciated every year, with or without the pandemic. Someday we'll get back to doing this in person.